So although the literature is not tremendous on it, ATLS bid on it lock, stock, and barrel, which is the controlled hypotensive resus. So they want you to give less fluids and earlier blood products. So the old idea of 2 liters of crystalloid wide open in a trauma patient to see if they're a responder or not, the new version of ATLS is slow down there, 1 liter, they want less fluids. At least one thing that happened that used to cause lots of problems was they always used to insist on lactated ringers, and we would always be hanging normal saline, and the surgeons would come up, what about the lactated ringers? And now they finally have given up on the lactated ringers at least. So the only place that lactated ringers is left as the standard is where it belongs, which is in burns. And the reason you need lactated ringers in burns is because the volume you're giving is so great in a large surface area burn that if you gave normal saline, you'd be getting into a hyperchloremic acidosis. But for the rest of the time, they're okay with NS. And part of the reason they went to saying okay with normal saline is because lactated ringers is technically not compatible with blood. So the American Blood Banking Association says they're incompatible solutions. And if you're going to be going to blood earlier in trauma patients, you'd like to have up a compatible solution. And the reason is that when you have lactated ringers, the calcium in it causes microaggregates to form. And those microaggregates, even if you hang it filtered, are one of the contributing causes of TRALI, transfusion-related, transfusion-associated lung injury is what TRALI stands for. TRALI is mostly a problem with platelets more than packed red cells, but it is associated with both. So we're now at least to normal saline. And what we have here is 18 is a paper that looked at this delayed or controlled hypotensive resus, and it's an analysis of the literature on this and it says, you know what, we don't really know the answer, so individualize your management. That's probably the truth of where the science is, but you should know that ATLS is bit. Now, we could have a long conversation about this. Where I think that the whole idea here is if you've got a lesion, a vascular lesion, you're bleeding. And if you bring the blood pressure up, what's going to happen? They're just going to bleed more. And particularly they're going to bleed more if it's a large vascular lesion, plus the fluids you're giving are causing a dilutional coagulopathy on top of it. All that's going to make them bleed more. This is probably true, and so we pay attention to this controlled hypotension with penetrating chest trauma, penetrating abdominal trauma, where the potential for large vascular injuries is high. However, having noted that, most trauma does not involve large blood vessels. Most trauma involves small arteriolar bleeds, which this has never been shown to be important for. So this whole argument, if you look at paper 20, down at the bottom, this is the original paper by Susan Stern, who's the chair up in, where is she, Oregon, Washington. It's her original paper where they sewed a wire into the aorta of a pig, then they let that heal, and then they snatched the wire out. So the pig has a known 2-centimeter aortic lesion. And then they looked at different resuscitation models and see what happened. And if you resuscitate that pig back to normal vital signs, they die earlier and they shed more blood. And if you resuscitate them partway to hypotensive vital signs, they live longer and they don't shed as much blood. So for a large vascular injury where wound geometry is important to clot stabilization, this is probably true. But for the rest of trauma, to say that a hypotensive resus is the way to go, we don't really know. Having noted that, ATLS has bought off on it completely. Now, damage control hematology is the next topic on page 234. This is the whole idea that we used to give blood, and then when their coagulopathies were off, we would then give fresh frozen, and if their platelet counts went down even later, we would give platelets. And now people are going with this damage control hematology concept, which is when you see someone who's bleeding a lot and you think they're going to need more than 3 or 4 units of blood, either in the ED or after hitting the operating room, you think they're going to need a large volume of blood, then you should just start giving them factor replacement immediately, which is for every unit of packed cells, give them a unit of fresh frozen. And then the question is, should you also be giving a unit of platelets with that? In other words, you'd be giving them whole blood. Now the problem is that you can't give whole blood anywhere in the United States except under 2 circumstances. 1, you're in the military, they give whole blood. And 2, it's your own blood, which we took out of your chest tube, which we'll give back to you. We'll give you that whole blood. But since other than that, there's no way to get whole blood, the question is, what's the optimal ratio? Now, most of the studies that have been done, and there's a couple papers here looking at it, are vaguely positive in favor of FFP ratios going up. And what I want you guys to understand is that the evidence bar for FFP is much lower than the evidence bar for platelets. Why so? Because FFP is cheap, relatively available, and has a low complication rate. Platelets are expensive, have the highest complication rate of any blood component, and they're relatively unavailable. They're a treasured resource at your hospital. So I'm very easy to accept one-to-one, packed red cells to FFP, but you got to show me pretty good evidence to make me go one-to-one-to-one. The platelet evidence has to be much better. So where are we, in my opinion? I think we're at the place where I would accept one-to-one for packed red cells to FFP. I'm good enough with that. I think we've exceeded that, but we haven't exceeded the level of evidence to know that the platelet number is right. The good news is a large prospective randomized waiver of consent trial looking at this is underway. It's called the PROPER trial, and we'll have actually good prospective randomized data rather than retrospective sort of bullshit analysis to tell us what the right ratios are within a few years. Paper 22 is a fun paper that says all this stuff says that says one-to-one-to-one is better than the old way is screwed up by what's called survival bias. This is the Emperor Has No Clothes paper. He points out that in a lot of papers that say the survival of the one-to-one-to-one group looks better than the ones that got standard because the standard ones died before they could get their transfusions. So it's unfair to populate the group that didn't get the one-to-one and add them in the analysis when the reason they didn't get it was they died. That's not fair. You have to look at the ones that lived and then compare them. So this talks about that among these papers that look at damage control hematology, and I completely agree with the author's analysis, that survival bias, in other words, people died in the arm that you said didn't do as well, is an unfair part of the math that's been done so far. So that's there for your fun. How about recombinant factor 7A? It's died an ignominious death. The military killed it, and what they found was not only was it super expensive, but it kills people. So it has a bad side effect side to it, a prothrombotic side, and that even compassionate use of recombinant factor 7A has been effectively challenged. So recombinant factor 7A is a great intervention for your hemophiliacs and some of these other things where there's a bleeding disorder, but in trauma or head injury and things like that, it's very expensive and it hasn't yielded good results. And abstract 23 says the use of recombinant factor 7A was associated with an increase in mortality and no decrease in major complications. And so I think recombinant factor 7A is largely dead. There have been a whole bunch of papers over the last 4 to 5 years talking about the demise of recombinant factor 7A as a thought. Now, we get to the next group of papers on tranexamic acid, TXA. TXA is cheap. It's about $200 a dose. There have been a couple of big trials. They're weird trials to wrap your head around. Let me introduce you to the concept of what we're doing here. We have a thromboelastogram at LA County, and if you take trauma patients who arrived, multi-system trauma patients, and you take their blood and you put it in a thromboelastogram, so-called, we call it a TEG, and what that does is it takes whole blood and it spins it around on a toothpick really fast, and it sees how fast the clot comes apart. So it looks at the performance of whole blood, which is something that your ProTime and your PTT and all those things don't do. And it creates a whole new science of bleeding. What we find when you do that with trauma patients is that somewhere between 10 to 20% of all trauma patients go into a fibrinolytic state shortly after trauma. You can imagine that going into a fibrinolytic state after you have trauma is not a particularly good thing to have happen to you. And in fact, at our hospital, it was about 11% of patients went into a hyperfibrinolytic state, and their mortalities were terrible and didn't follow their injury severity scores particularly well. If you went into a hyperfibrinolytic state after trauma, that was a really bad thing. So what does tranexamic acid do? Well, tranexamic acid is an inhibitor of fibrinolysis. So theoretically, if you're going to give this to all trauma patients, it's not going to benefit all of them. It's only going to benefit the 10% or 15% that go into this hyperfibrinolytic state. But those patients are so disproportionately at risk for dying from their trauma that fixing it for them might be a big benefit. Now, the other thing about tranexamic acid is, unlike any other drug that's on the Y, and by the Y I mean extrinsic pathway, intrinsic pathway, common final pathway, when you mess with drugs on the Y, we know that the therapeutic index is going to be really narrow. You're either going to start bleeding problems or you're going to start clotting problems. And we see this with thrombolytics, we see this with heparin, we see this with Coumadin, we see this with all of these drugs that we know that when you mess with something on the Y, you know, it's not, because your body right now, if you think of how your body works physiologically, inside each of you at this moment is enough clotting factors to turn you into a jiggling bowl of Jell-O almost instantaneously if I was to activate them all. Boom, you would just clot. And so the way your clotting system works is it's pulse activated and rapidly pulse inactivated. You make a clot where you need to shut that shit off. That's how it works. Because, and similarly, you have enough stuff in there to make all of it go to, you know, dilute Kool-Aid and have you bleed forever. It's a very delicately balanced system. Now, in terms of what activates that system, is the most potent activator of that system is exposed basement membrane. And the way you expose basement membrane is you injure a vessel. It exposes basement membrane. There is nothing that pisses off a platelet like exposed basement membrane. That will make you, all your platelets will turn into an echinocyte, they'll degranulate, you will clot. And then you have to shut that system off. The good news about tranexamic acid is it's not on the Y. That means it has the potential to be a much safer drug. And in the CRASH trial, which had 20,000 patients in it, it's in here. It's, CRASH is 26. It's a weird trial, 20,000 trauma patients, some of whom weren't hypotensive, a bunch of whom weren't bleeding. They gave tranexamic acid to them all. It was done in something like 26. It was done 270 hospitals in 40 countries. Some of the largest enrolling countries were like India, where you might think, well, how's trauma care in India like trauma care in downtown London at the Imperial? Is it really the same? Can we compare these patients to each other? In fact, the study was so weird in terms of the undeveloped countries that it was done in, is they had to have different randomization protocols for the hospitals that were registering patients that didn't have a telephone. Think about that first. Wait, there's a study, there's a hospital enrolling patients in this trial that doesn't have a telephone? Yeah, there were. Anyway, so it's a huge trial. The benefits were there, and most people say, when they look at this, they say the trial was too weird. But there are a couple things about this trial. One of the things about a trial with 20,000 patients is that if this drug caused complications, it was a large enough trial to find them. Right? Complications, you need big trials to find them. You need large numbers. So one of the things this trial did was establish the safety of tranexamic acid. It proved that a drug that's not on the Y can be given relatively safely without developing prothrombotic complications. That's important. So the safety of this drug, because when every other drug we talk about on the Y is a dangerous drug. This is off the Y, it's a relatively safe drug, and it's cheap. Now, even in this study where people weren't bleeding and some of them weren't hypotensive, it worked for the smaller percentage. So the people who look at this trial say it's a weird trial and it's a bad trial and there's all kinds of problems with the trial, but all of the problems with the trial would have underestimated the benefit of tranexamic acid, not overestimated. So while there's all these criticisms about CRASH, everyone pretty much agrees that while there are problems with CRASH trial, they all would have underestimated the benefit of tranexamic acid, not overestimated it. So then we have the other trials that are before 26, we got 24 and 25, which all found that this stuff worked. It's not a huge benefit in survival, but it's a pretty consistent benefit in survival. So if you look at 25, which is in brain injury, rates of composite poor outcome or new focal cerebral ischemia or need for neurosurgery were 45% in the tranexamic group versus almost 60% in the controls. That's in head bleeds. That's a pretty big effect. We don't got a lot of things for head bleeds. That's a pretty big effect. And in the whole trauma group, it was a couple percentage points decrease in trauma deaths. So tranexamic acid, a lot of people are saying it's time to have it. We're using it now at our hospital. It's in our trauma protocols. We give it early, which in the crash trial, giving it earlier was better than giving it late. And so you may hear a lot more about TXA, and in ATLS, they bit on TXA. They're okay with tranexamic acid in the new ATLS. There was what?
I thought there was some problem.
Oh, there are lots of problems with the crash trial in terms of the methodology. How? So after the crash trial, there's the MATTERS trial, which is an Army trial. That was good. There was CRASH 2. That was good. So far, most of the data, and by the way, TXA has been studied in lots of other things. It's been studied in post-dental extraction. Good. It's been studied in women with menstrual bleeding. Good. It's been studied in gynecologic surgeries where there's big hemorrhage problems. Good. It's been studied in cardiovascular surgery with post-cardiovascular surgery bleeding. Good. So across a wide array of things, there's a big sort of mound of momentum behind the tranexamic acid push, and it doesn't come just from the trauma setting. It comes from a lot of other surgical settings. The bulk of the literature is very good. The thing doesn't have a bad side effect profile. It's relatively cheap, and particularly for those trauma patients who are going to go into a hyperfibrinolytic state, it seems to offer advantage. The real question is, rather than giving it to all trauma patients, why don't we find out which ones are in a hyperfibrinolytic state and give it to them instead of giving it to everyone? Because you can bring the thromboelastogram as a bedside test. So one of the things that'll be interesting to see if TEG testing moves into the ED. How about hypertonic saline? There are those of us that hypertonic saline is great. It allows you to resuscitate the periphery without increasing intracranial pressure. And everyone said, yeah. And there were some great animal studies, and there were no endocrine side effects, and the salt load wasn't a problem. And then Cooper's the killer. Cooper's an Aussie guy. So then Cooper did this trial 27, where he took a bunch of really seriously head-injured people and tried the hypertonic saline, and it didn't work. Didn't work. Pre-hospital administration of hypertonic saline had no benefit. And so what did people say when they saw the Cooper trial? The hypertonic saline fans said, oh, these patients were too sick. The problem with that argument, they were so sick that you can't give hypertonic saline to a pumpkin and expect it to be something other than a pumpkin at the end of it. The problem is that if you were designing a trial to show benefit, do you want to enroll well people or sick people? You wanted to enroll sick people. And so the people who said too sick, it's like, all right, come on, give us a break. We got sick people, we enrolled them, they didn't benefit. And so these people are saying, well, you needed less sick people than that. Sick, but not that sick. Anyway, I don't think hypertonic saline causes a lot of harm. I don't have a problem with using it, whether you want to use 3% or 7%. You know who was interested in hypertonic saline at first, right? Was the military. Why was the Brooke Army Institute involved with this? Because in Vietnam, when they had all of those mine injuries and high muzzle velocity injuries with big bleeding, femur fractures and stuff, one of the problems they found was they fly the medic out in a helicopter, and the medic would drop down. There'd be 7 people injured, all of whom needed 2 liters of saline. Wait a minute. Did the medic leave the helicopter with a wheelbarrow filled with saline? How are we going to get all that saline to the injured soldier? So then they said, what if we put 250 cc's of 7% normal saline on every soldier's belt? Because that's the equivalent of 2 liters. They said then the medic doesn't have to carry any fluids. Each soldier will carry their own resuscitation fluid on them. Unless they get shot in the hypertonic saline, the medic doesn't have to carry anything. And so that's why the Brooke Army Institute got interested in 7, and that's why their numbers are much more concentrated saline. Like if you talk about Cooper's paper, I think it was 3% saline. Yeah, they use 7.5, but lots of the papers use 3%. At our hospital, if we're going to use hypertonic, we use 3%. But in the Army, they use 7.5%. There you go. Anyway, is hypertonic saline good or bad? In ATLS, they're okay if you choose to do it. They leave it up to you and the trauma surgeon involved as to whether or not you want to use hypertonic saline. I don't think it causes any harm, and at least it's not expensive. Then we start on abstract 28, going into the papers that talk about, let's not be ridiculous. In ATLS, they used to say every trauma patient needs a chest, C-spine, and pelvis. Everyone needs a rectal. Everyone needs a Foley. Everyone needs an NG. And there's a whole bunch of papers here that say, please. I'm pretty sure they don't have a pelvic fracture if they walked after their car accident and have no pain. Please, I'm pretty sure that we can avoid the C-spine injuries on people who are clearable by nexus. Please. You really think I need to do a rectal exam on a guy who was shot through and through his upper arm? I mean, it's hard for me to imagine how the rectal will benefit him other than humiliating him early on in his course. And so abstract 28 says there's no such thing as an occult pelvis fracture. If you break your pelvis, you'll know. Abstract 29 and 30 and 31 and 32 say be reasonable about the rectal. If they have penetrating trauma near their rectum, sure, stick a finger up there. You think they got a spinal cord injury? Sure, do a rectal exam. You think they got a bad pelvis fracture where you might have disrupted their urethra or things like that? Do a rectal exam. But otherwise, the rectal exam is optional. How about Foley's? Does everyone need a Foley? No, obviously not. And abstract 33 says not only will they get urinary tract infections, but we underestimate the amount of Foley trauma, that people have hematuria and injuries. I think that's overblown. Do I think Foley? Have you ever been to the urology suite and watched them do a cystogram? Have you ever seen that? Where they put a pipe that's about this big up the penis, and you're like, oh my God, that won't work. No, when you see this happening, you're like, no, stop, you're going to kill him, please. And it goes right up there. So the idea that a Foley's causing trauma when we routinely pass large pipes up the penis, I think is pretty much a myth. But anyway, you know, common sense should dictate who needs a Foley, and there's lots of moves to decrease the number of people who get Foleys, because Foleys are associated with urinary tract infections and things like that, which are unnecessary. Abstract 34 says you don't need a Foley. And abstract 35, my favorite thing over the years with trauma is you got a patient who you're actually worried about their neck in a C-collar, who's been in a bad ejected from a vehicle, rode their motorcycle off a cliff, jumped from a tall, but whatever it is, you're really worried about them. And the R2 from surgery is trying to put an NG tube down this patient. And they're there in a collar going like this. Which is, what they're saying is, not the left nair, not the right nair, neither nair, I don't want it. And every paper that has asked patients about the things that we do that are obnoxious to them, right at the top of the list of things that we do that are obnoxious to patients that they really hate, and it comes out over and over again, the same three things. They really hate ABGs, and I can't think of a good reason for doing one in 2013. You got the VBG, you got the pulse ox, you got the waveform end tidal CO2. What in God's name could you possibly want an ABG for? I don't know, but anyway, and patients really don't like them. NG tubes, right at the top of the list, they really don't like them. And Foley's, in fact, when they asked women, there was one of my favorite papers that's in the database, when they asked women who are going to get an ultrasound, a pelvic ultrasound, which do you prefer? Do you want the pelvic ultrasound where they put the condom on the big sword and push it into your vagina and look around? Or do you want the Foley, that you need to have, so that they can fill up your bladder to do the transabdominal ultrasound? And what did women say? The people who did the study thought they were going to say they want the Foley. And all the women said, no Foley, I'm okay with the vag probe. Please, I don't want the Foley. So Foley's not well liked, and there's a bunch of papers saying you don't need to do it. Abstract 36, another thing that was part of emergency medicine practice, which the surgeons ignored for years, was us doing fast exams or EFAST exams or rush exams. They just didn't believe them. And after that, we got abstract 36, 37, and 38, which are part of the reasons they don't believe it, which are all papers that say that that a fast exam doesn't rule out intra-abdominal injury. Yeah, I think that's what we've said all along. So they just never heard us in emergency medicine. Finally, they heard us. What we told them was the fast exam is useful when it finds fluid. If you find free fluid on a fast exam, the likelihood that they will need a therapeutic, not a negative lap, a therapeutic laparotomy is high. A positive fast exam in a blunt abdominal trauma patient correlates very highly with the need for a therapeutic laparotomy. We never said a negative fast exam means you're okay. So they got these papers here, 36, 37, and 38, which are all about surgeons wenching about the fact that a negative fast exam does not mean you're well. And the emergency physicians are like, yeah, that's because you don't listen to us. We never told you a negative fast exam means you well. We told you that a positive fast exam means you not well. Please understand what we've been telling you. But anyway, finally this year in ATLS, they accepted the FAST exam. They even have a teaching station on the FAST exam, and they got a model and one of them Jello things that you can look at for positive FAST, and they finally have recognized that they're not going to dissuade emergency physicians from doing FAST exams, and they finally acknowledged in ATLS that they actually will go to the OR based on our FAST exams. They're not quite ready to accept the EFAST, which is where we tell them there's a pneumothorax before the chest x-ray has been done, but in our hospital, all pneumothoraces and trauma patients are found by ultrasound long before they're found by x-ray. They don't know what a transition point is on an EFAST. They don't understand what a rush exam is, and documented for you in here. In our hospital now, and I granted, you know, I understand my practice environment is 3 standard deviations out. It's a 131 bed level 1 trauma center with 31 ultrasound machines in it. 31 ultrasound machines is what we got. Every trauma bay, you don't have to wheel the ultrasound machine in, it's on the tower. Their vital signs are here, their ultrasound machine is there with a long probe, and our residents, you know, the residents, I consider myself to be pretty good at ultrasound, but the residents still scare me. Like I walked into the room the other day and there was a resident with a vag probe on this guy's neck, like this. And I looked at, with a big mound of jelly like this, a huge mound of, and the vag probe on this guy's neck. And I walked into that resident, I was like, psst, what are you doing? The resident looked at me, I said, that's not a vagina. And the resident looked at me and said, yeah, but the vag probe has an angled array. I was having trouble getting over the clavicle to look at his carotid takeoff. It is what I thought. He's got a flap in his carotid. You can see it right here as it comes. I was like, as you were. Please follow it with a definitive study. Yeah, he goes, I thought he had a carotid dissection. Now I could see it. I was like, all right. You know, and I remember the first time I walked into a room and saw a resident with a big mound of ultrasound jelly on someone's eyeball. I was like, what do you do? What him do? And now we're really comfortable with ocular ultrasounds and things like that. But anyway, I detailed here for you where the ultrasound is going. Every patient in shock at our hospital gets a rush exam. And it's what we know about shock is that the vitals don't tell you whether it's obstructive shock, distributive shock, or hypovolemic shock. And the differentiating between those 3 shock patterns is really important. Obstructive shock happens in trauma. How so? Tamponade is a form of obstructive shock. Attention pneumothorax is a form of obstructive shock. Obstructive shock, when it's present, means do procedure now. That's really important in trauma. Finding obstructive shock means do procedure now, because cardiac arrest is imminent. And distributive shock is an important thing to identify. It doesn't happen often in trauma, but it does in spinal cord trauma. We did a rush exam on a patient with a gunshot wound to his neck and a gunshot wound to his belly. The trauma surgeon, he had a negative FAST exam despite the gunshot wound to the belly, and the surgeon wanted to go low volume with the resus, and I wanted to go high volume. But that's because I knew what the rush exam was saying. The rush exam was saying no free fluid, flat IVC. He's in spinal cord shock from the gunshot wound in the neck, not in hemorrhagic shock from the gunshot wound to the belly. So the surgeon and I were on different pages. He caught up to me when the patient crashed his pressure a little later. Anyway, there you go. But there's your rush exam for you to look at if you want to see those. All right, how about head trauma and minor head trauma? So ATLS, again, I can't believe how much change happened in ATLS with this iteration. Canadian head CT and New Orleans rule in. They read our literature. They didn't ask us to write the chapter, but okay. At least they're paying attention. In terms of, we were asking about pediatric C-spine, on page 244 are the detailing of the Gergen guidelines and the Hansen high-risk guidelines, which say this: if a kid, for example, has high-risk features to their trauma, then you should scan their neck. And if the kid has no high risk, and you really don't think, because the incidence of a broken neck in peds is low, right? They got a really mobile neck. Incidence is low. In adults, it's 2% of all trauma. In kids, it's like less than 0.5%. So the incidence is very low. And they say in the absence of these high-risk criteria, you should go ahead and get plain films, so you're not irradiating the kid's neck. And I agree with that. What does ATLS say? ATLS says scan all pediatric necks. I think that's wrong. And where do they get that idea from is really abstract 46. This guy Balitz thinks that you got to scan all necks because plain films aren't good enough because they miss stuff. And I agree with that. I'm not arguing that plain films are as good as CT. I'm arguing that if the pretest probability is low, then plain films will be an adequate way to screen for them without the attendant risk and cost charge, I see you're still back there, Greg, of a CT scan. So I think that plain films are not dead, but ATLS thinks plain films are dead unless you're in a place, and they say this in the manual, unless you're in a place that doesn't have a CT scanner. They really want you to scan all your necks. I just put it out there. There you go. In kids, when I ran the numbers at our hospital, and they were not pleased with me, the trauma people were not pleased with me when I did this. When I ran the numbers on scanning, doing CT scans of the neck in kids who are low risk, because the fracture rate's very, very low, when I ran the numbers for them with the estimates of radiation from our scanners and all that, and I told them that they would cause 5 cases of thyroid cancer, and 1 kid would die of that cancer for every fracture they found, they were like, oh no, I think you got the math wrong. No, that's what the math is. That's what the math is. That's why we can't scan all of our low-risk kids, because you'll cause 5 cases of thyroid cancer, 1 kid will die of that thyroid cancer for every fracture you'll find. That's why you can't do it. And then that takes us to the final thing that I commented on here, and I downloaded this picture of the sheep for you. They finally have allowed you to not kill an animal as part of ATLS, and I've been after them for this. And I'm not a PETA person, don't get me wrong. I believe that we should kill animals before we kill grandmothers. But for most people taking ATLS, the only thing they learned by putting a chest tube in on a sheep or a dog or a pig was sheep, dog, and pig anatomy, which hasn't turned out to be that useful for me in my day in and day out practice. And so the animal practicum, especially in this day and age, as simulation has gotten better and better, it's become harder and harder and harder to justify the animal practicum, not to mention the cost of it, et cetera. When you pay for an ATLS course, about 2/3 of the cost, now I don't see them lowering the cost of the course, but I'll just tell you, about 2/3 of the cost was the vet and the animal practicum. 2/3 of the cost. So, you know, in the developing countries, they're still killing pig, sheep, and goat, and still in some places of the United States they are, but in many places they are now finally allowing you to be a conscientious objector and say, I'm not going to do ATLS if I got to kill a dog. I particularly objected to killing the dogs. I never mind killing the pigs as long as we got to eat them afterwards. You know, as long as we're not going to just throw it away. I object with killing an animal and throwing it away. That I don't think is right. But anyway, so there it is, the data on it. And so that's it for ATLS. In balance, I think the new ATLS manual will result in far fewer conflicts at the bedside. Generally speaking, there has been a merging with emergency medicine practice regarding RSI, regarding fluids, regarding FAST, regarding all kinds of stuff. Generally, there's a merging. Are there still places where there's going to be conflicts? Oh, yeah. Are trauma surgeons still trauma surgeons? Oh, yeah. Are they still imaging the crap out of people with pan scans? Oh, yeah. All that's still there, and ATLS won't change that. But in terms of how objectionable the course is, much less objectionable. Thanks.